Today's session. Very good afternoon. So we have Anita today. I take this opportunity to formally introduce her and without any delay. So July is supposed to be Dry Eye Awareness Month. I am sure, being optometrists, we all know that. On behalf of OCI, I am absolutely delighted to welcome you all to this Dry Eye Awareness Month with a special webinar. The title is Understanding Dry Eye in 2025, the key takeaways from the TFOS Dry Eye Workshop 3. Dry eye disease continues to be one of the most prevalent and complex ocular surface conditions impacting quality of life worldwide. As we move in 2025, new insights from the TFOS Dry Eye Workshop offers updated perspectives on the definition, classification, pathophysiology, diagnosis, and management of dry eye diseases. We are honored to have with us today Dr. Anita Arvind, who has been closely involved with dry eye research and is well versed in the Dry Eye Workshop 3 findings. Dr. Anita is an associate professor and HOD of Optometry School of Healthcare and Allied Sciences, GD Goenka University, since June 2023. Dr. Anita Arvind is a distinguished optometry professional with over 22 years of academic and clinical experience. She completed her optometry degree at the renowned Elite School of Optometry and went on to earn a master's degree in clinical optometry with a gold medal from Amity University. Later, she obtained her PhD from the University of KwaZulu-Natal, Durban, South Africa. Dr. Arvind is the co-founder and director of academics at Learn Beyond Vision, an innovative platform dedicated to advancing the skills and knowledge of eye care professionals. In India, she also serves as a senior co-educator for Rose-K Lenses and leads the Advanced Contact Lens course, ACLC, organizing workshops and hands-on training sessions for optometrists nationwide. She played a key role in establishing the Lotus College of Optometry in Mumbai and the School of Optometry in Gwalior. I can go on and on because she has a huge list of her contributions towards the profession, but I think this is it. And over to you, Anita.
Thank you so much, Paula, for that kind introduction. So let us not waste much time and plunge into the topic of the day. So before that, a very good afternoon to one and all, and thank you for being here today. So dry eye disease continues to be one of the most common yet complex ocular surface conditions that we are managing today. So, how many of us keep seeing patients who keep coming back to us again and again with unresolved dry eye symptoms despite giving the best of the treatments or offering the best of the care? That's a signal that our approach needs refinement, and that's exactly what the T-Force Deuce 3 gave us an opportunity by giving us new insights as far as the pathophysiology of dry eyes is concerned, the diagnostics, as well as stressing on the importance of personalized therapy. To me, this T-Force Deuce 3 report is pretty exciting, and I'm very happy to see the lovely algorithms that they have given us, which is enabling us to simplify the understanding of dry eye, and also it's easy to implement in clinical practice. To me, the current Deuce 3 report is more clinician friendly, I would say. In today's session, I will take you through the highlights of the T-Force Deuce 3 reports with a focus on three core areas, mainly updated definition and the diagnostic criteria which they have come out with, the evidence-based management algorithms, and finally, I will give you an overview of the digest report. So before I jump into the topic, a quick word on T-Force and Deuce. T-Force is the Tear Film Ocular Surface Society based in the USA, and they gather all the experts from across the globe, and they deliberate they kind of come out with these evidence-based reports and share the findings with the entire world, and they also form policies with regard to the dry eye disease. Now, the DEUCE is the dry eye workshop which is being conducted by the TFOS.
the Tear Film and Ocular Surface Society. The first report came out in 2007. The second one came out in 2017, and the current one is DEWS 3 report, which has come out now just a month ago in 2025. And between 2017 and 2025, they also came up with the T4's lifestyle report, which came in 2023. Okay. So, okay. Coming to the T4's DEWS 3 reports, as I mentioned earlier, the first report which came out was the diagnostic methodology, wherein Professor James Olfson, he was the lead author in this report, followed by the management and therapy report, where Professor Lyndon Jones led this report, and lastly, the digest report, which was led by Professor Fiona Stapleton. Okay, so these three reports have been published in the American Journal of Ophthalmology, and they have been online, and it is free access. Anybody can access these reports, and they're pretty voluminous. To talk about the number of people who contributed towards these three reports, there were around 150 international experts spread over 36 countries, and over 1,000 articles were referenced. To be precise, it was exactly 1,057 referencing of articles done in these three reports. So you can see the magnanimity of this report and how important it is to us. So why was the diagnostic methodology report, come? So why? Because we needed standardization of the dry eye disease diagnosis. So if you look into the literature, so dry eye disease is basically having a variable prevalence. It ranges anywhere between 5 and 50%, and somewhere even 60 to 70%. This variability is because of the different diagnostic protocols that were being followed by researchers across the globe, and even the cutoffs that were being used were very much variable. So in order to standardize these diagnoses globally, the diagnostic report has come about in 2025. This ensures that there is consistency in care. It facilitates early diagnosis, improves better patient outcomes, and supports the health policies. And it enables accurate prevalence estimates, facilitates regulatory approval and treatment validation, and supports interdisciplinary care. So now with the current diagnostic criteria that has come about, the future research will all be based on this. So we'll have kind of uniformity in the prevalence rates, and it won't be too variable as it is in the current form. So coming to the dry eye disease definition. So in 2017, we did hear about the dry eye disease definition, but there is not a radical change in the definition. To just read this definition, dry eye is a multifactorial symptomatic disease which is characterized by a loss of homeostasis of the tear film and or the ocular surface, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities are etiological factors. So a couple of words are underlined over here, because dry eye is a multifactorial disease and not a syndrome, which was earlier thought to be. Now, what's the difference between a syndrome and a disease? When a group of people experience similar signs and symptoms but with unknown etiology, we can't really pinpoint or be very certain about the etiology of that condition, it's a syndrome. Earlier, we couldn't really pinpoint what was causing dry eye. Hence, it was addressed as dry eye syndrome. But now it is definitive, because more or less we are, quite certain as to what are the etiological drivers towards development of the dry eye condition. So now it is a multifactorial symptomatic disease. Earlier definition in 2017 said it was associated with symptoms. Now it is confirmatory that it is always symptomatic. And of course, characterized by loss of homeostasis of the tear film, and hyperosmolarity is the key factor involved in the development of dry eye disease, which kind of triggers a cascade of events towards the development of the ocular surface inflammation. Now, the best part or the beauty of these reports is are the algorithms that they have shown, and these beautiful Venn diagram which says that to confirm that somebody has dry eye disease, both signs as well as symptoms must be present. You see the red area marked over here where both the circles meet, that says that it is dry eye disease. You can't have someone experiencing symptoms, but there are absolutely no signs on the eye to be called as a dry eye disease, and vice versa. So to confirm that someone has dry eye disease, both the signs as well as the symptoms need to be present. And of course, you need to have the differential diagnosis in place. You have to eliminate what are the other things that is not affecting or causing the dry eye. So this is again a quick guide to tell you that how do you confirm the symptoms. The 2017 report on diagnosis mentioned that you can use either of the two questionnaires, the OSDI or the DEQ-5 questionnaire. But now the current report says that you can do away with all the other questionnaires and just run the OSDI 6 questionnaire, which is an abridged version of the original questionnaire, which had 12 questions. So now they just have to go through the 6 questions, and the recall period for the original version, the 12 questionnaire, was about 1 week. But here the questions in the OSDI 6, the recall period is for the past 1 month, as in if they have experienced blurred vision. The second question on the questionnaire, I am not too sure if you can read it. It asks blurred vision. Have you experienced any of the following during a typical day in the last month? Have you experienced blurred vision? So whether it's been constant or most of the times or often or sometimes or never, you need to circle that relevant response. So it is very quick. It can be easily administered. So rash analysis was done, which means it is pretty much validated and comparable to the original OSDI questionnaire, which had 12 questions. And this can be easily translated to any language also. I mean, Chinese translations have also been done earlier and found to be pretty useful in getting the symptoms. And this can be run on children as well, because children have very short attention span. So 6 questions are very simple for anybody and everybody to answer also. So that's the best part which this report has given us, is an abridged version of the questionnaire. So for all of you who kind of face dry eye patients in your practice, so do administer the OSDI 6 questionnaire, which is easily available on the internet also. So a score, the cutoff value over here is 4. 4 and above value is confirmatory that the patient is symptomatic for dry eye. Okay. So if the score is anywhere between 0 to 4, it means that they do not have any symptoms. 4 to 8 is moderate, and anything above a score of 8 is severely symptomatic for dry eye. Okay, so that's how you categorize the symptoms. Coming to the signs, I mentioned that signs are equally important as symptoms are. So just the symptoms are present and no signs does not mean it is dry eye. So non-invasive tear breakup time is a recommended test that you need to do, wherein the cutoff is anything less than 10 seconds means confirmatory that the tear film is unstable. And if that cannot be done, or you have access to a tear lab where you can check for tear osmolarity, that is also good enough, wherein the cutoff is 308 milliosmoles per liter, or an inter eye difference of 8 osmoles per liter is also a positive sign for tear hyperosmolarity, which is the hallmark of dry eye disease. And of course, staining the anterior ocular surface is very, very important. Here, two valuable stains need to be used. As optometrists, I would like to reiterate that you need to generously use these two dyes in your practice. Whether you are just handling regular OPDs or specific to contact lenses whatsoever, you need to use the lissamine green as well as the fluorescein, because any corneal stain can be picked up by the fluorescein, whereas the conjunctiva picks up the lissamine stain better. especially the bulbar conjunctiva and the lid margin, to look for lid viper epitheliopathy. When you notice 5 or more spots on the cornea which stains, then it is confirmatory. If you have 9 or more conjunctival spots, or you see a staining of the lid margin which is 2 mm or more, or you follow the Cobb scale, you don't have to memorize any of these. Okay, so you just have to look into the algorithm. The charts are available, and if any of these are positive, then they are positive for the clinical signs as well. Now, talking about the risk factor analysis, the current report plays a lot of importance on risk factor analysis and classifies them as consistent risk factors, probable risk factors, non-modifiable risk factor, and modifiable risk factors. Like, for instance, age and sex and gender, these are not, I won't say sex and gender, sex definitely non-modifiable. Gender is what the person thinks of himself or herself. So there is a difference between the two. I keep getting questioned by students when they say, when I say sex and gender, doesn't it mean the same? It doesn't mean. Sex means that the physiological being that is born with a certain set of chromosomes which determine whether you are a male or a female. You may be born a male, but you think that you are a female. That is gender identification. So there is a difference. So don't get confused. I'm sorry, I have to mention this because I keep getting questions from the students, and I thought I should mention or talk about this. So coming back to risk factor analysis, the report kind of identified 200 risk factors, but not all of the factors contribute towards the development of dry eye disease. This chart over here will easily give you or identify the consistent and the probable risk factors. But all along, we have been frequently talking about certain risk factors, but they have proven to be inconclusive in evidence. In the sense, a lot of research has happened which is not being very conclusive about their role in towards development of dry eye disease, like smoking, for instance, caffeine intake, alcohol, water intake, food restrictions, Mediterranean diet, menopause, air pollution from particulate matter which is less than 10 microns, are oral contraceptives. So earlier we used to believe that these contributed, or these are high risk factors towards development of dry eye disease, but the current report says that the evidence towards these risk factors are inconclusive. Not that you can eliminate, but do keep this in mind. So talking about the differential diagnosis, I know this is a very busy slide, but then there are so many areas that they have identified: eyelid related disorders, non-ocular surface disorders, other mixed and miscellaneous ocular surface disorders, cornea related disorders, and conjunctiva related disorders, which you need to differentiate from the true dry eye disease. Now, anybody having MGD doesn't mean that they are definitely a case of dry eye. You can have MGD, but you may not be symptomatic. So that can also be the case. So that doesn't mean that a person with MGD means definite of dry eye disease. So that's the reason why this slide is up here, that you need to, whenever you're taking history and talking to the patient, the communication needs to be open. You need to ask a lot of questions to be able to differentiate true dry eye from the others which contribute or mimic a dry eye situation in a patient. So coming back to the algorithm, I had mentioned it earlier too. I would like to reiterate that to confirm that somebody has dry eye disease, use the simple OSDI 6 questionnaire. Okay, the cutoff value being 4 and above, 0 to 4, no, not symptomatic, 4 to 8, moderately symptomatic, and any score above 8 is severely symptomatic. Okay, and then you can do either a non-invasive tear breakup time or an osmolarity testing with the tear lab. So for those of you who say that we have no access to checking the non-invasive tear breakup time or the osmolarity, you can always do the fluorescein tear breakup time. Of course, that is an invasive procedure, but if the tear breaks up within 5 seconds, then it is confirmatory that the tear film is unstable. And ocular surface staining, like I mentioned earlier, you need to use both fluorescein as well as lissamine green to ascertain the staining on the cornea and the conjunctiva. So for cornea, you can just use the fluorescein dye, and for conjunctiva and the lid margin, use the lissamine stain. Okay, the cutoff values are all mentioned over here. It is available for open access, so all of you can access these reports and get, it's simple to get a printout of this and paste it on the walls of your clinic for easy understanding. Again, this is a very simple slide over here for you to understand that, if you notice that the patient is symptomatic when there is a score of 4 and above, and then you do a slit lamp evaluation, and I look for the signs for dry eye. If there are symptoms and there are no signs of dry eye, so it veers towards neuropathic pain, wherein the cornea is, that cornea is richly innervated by nerve fibers. So the cornea is highly sensitive. So they may be highly symptomatic, but clinically you're not seeing any signs of dry eye. So your modality of treatment will become different, because you're no longer categorizing them as a dry eye patient. Now, if you notice, signs but there are no symptoms, then it veers towards ocular surface disease, and that person could become symptomatic eventually or later, or it can veer your management towards neurotropic conditions. Now, once this is done, you ascertain that the patient is symptomatic, has the clinical signs of dry eye, you exclude the differential diagnosis, and then come to a conclusion that this is indeed dry eye. Once that is done, then you need to come back to subclassification. Now, this is where the 2025 report is focusing on. Earlier, we used to classify dry eye disease as either being evaporative dry eye or aqueous deficient dry eye or a mixed dry eye. Later, it became obvious that two-thirds of the dry eye conditions were evaporative in nature. So there are other etiological drivers which contributed towards development of dry eye disease. And that's why the subclassification gained loads of importance in the current report. So they classified one as the tear film component, wherein you differentiate whether it is a lipid layer of the tear film which is deficient, or the aqueous layer, or the mucin layer. Then coming to eyelid abnormalities or the anomalies, like blink or lid closure related issues or lid margin related issues which is causing the dry eye. So you manage them accordingly. And then comes the ocular surface and adnexa, whether it is because of the anatomical juxtaposition or the corneal nerves and sensation or the ocular surface cell damage or disruption or primary inflammation or oxidative stress that is causing the dry eye signs and symptoms, or associated systematic conditions. The whole point of this report was the extensive or elaborate subclassification of the dry eye disease. Okay, it was not just ascertaining that signs and symptoms are present, it is dry eye disease, and go about managing. Now, how do you manage is very, very important, and management is purely driven by the diagnosis. What exactly are you diagnosing? Whether it is a tear film component which is having a problem, you could have a situation where it is a lipid deficiency followed with a lid margin condition. Like, for instance, you can have a lipid deficiency and then which is causing the evaporative dry eye, and then the person could have meibomian gland dysfunction also, along with along with some pain also associated, because it is a neuropathic condition too, because of diabetes or any other situation. So you need to manage, you need to identify what is the etiological driver, and then customize your treatment or management for that particular patient. So the whole Deuce 3 report concentrated on classification, finding out what is causing the dry eye disease, and tailoring your treatment. It is not one size fits all. You customize or tailor make your treatment or management protocol based on these etiological drivers. So the key takeaways from the Deuce 3 diagnostic report is the revised definition of dry eye disease, which is it is multifactorial, it is a disease, not a syndrome, and it is always symptomatic. Standardized screening and diagnostic criteria is the OSDI 6 questionnaire, which is recommended. Key homeostatic markers are the non-invasive tear breakup time, the tear hyperosmolarity, and ocular surface staining. It is an etiological driver-based subclassification, no longer just aqueous deficient, evaporative, or mixed. It is more than that. You take the lid margin, the ocular surface, and adnexa, and all of that. So the recommended test sequence go from the least invasive technique of diagnosis to the most invasive. You start off with the non-invasive tear breakup time, and you can check for osmolarity if you can, and then instill the dye and check for the corneal staining and the conjunctival staining and the lid margin staining. And it is important to look for the risk factors and the differential diagnosis. Future directions, the role of AI for objective image analysis. Like for instance, if you notice, even when you're checking for clinical signs, the tear breakup time, so inter-observer variability could be there. I could have missed out the tear breaking up on some random place on the cornea. Somebody else would have picked up. So to eliminate that variability, you need to have something AI, intelligence based imaging technique, which is the future. And tear biomarker testing for dry eye disease subclassification, which I will be talking about a couple of slides later. Now, coming to the next report, which is the management and therapy report, that is completely driven by the diagnostic report. So it provides a contemporary overview of the dry eye disease management evidence, offers an evidence-based algorithm for therapy selection, considers dry eye disease subclassification based on the presentation of signs, symptoms, as well as diagnostic setting, focuses on new evidence since the TFOS DUCE 2 report, and detailed evidence supporting management options for updated subclassifications. So I'm just touching upon this part, which is like a point of interest for all optometrists, because the first line of management should always be towards replenishing, conserving, and stimulating the tear film. So lifestyle advice, a major chunk of this report also concentrates on the lifestyle advice that you give to each of your patients. You need to do analysis of their work environment and suggest, certain modifications. Simple thing like an USB supported, humidifier also makes a big difference in the lives of patients. Most of them are, confined in front of their desktops and laptops, and you can just plug in these devices, and the air around that area where they're working, it kind of humidifies, so that improves a lot in their work environment, and also improves symptomatically. And tear supplements form the cornerstone of dry eye disease. There are plethora of tear supplements that are available in the market. Now it has to be targeted. Not one tear supplement, makes a difference to everybody, I would say. Like, nowadays dry eye is become a very common topic. When you go for a family gathering also, I see people discussing, okay, this works wonders for me, this is the tear lubricant that's the best, and the other person would hear about it and then try it, and they find no difference in their symptoms. So you understand that what is good for somebody may not be effective for the other person. So here a targeted approach is very important. You need to specifically identify which component of the tear film needs to be targeted, because now for each layer of the tear film you have those kind of tear supplements, like if there is a lipid deficiency, lipid based eye drops are available. Tear lubricants are available. Likewise for aqueous deficiency and mucin deficiency, eye drops. Now, for example, lipid based lubricants are given for the evaporative dry eye patients and recommended 4 times a day for 1 month. If there is a symptomatic improvement, then this tear lubricant works, or this tear supplement works. And it takes 4 months for the same tear supplement to work on improvement in signs. That should also be noted. You can't just say that in 1 month just symptomatic relief is there, but signs remain the same, and you then move on to the next tear supplement. That's not the way we work. So that is why I've specifically mentioned, of all the treatment modalities that I've mentioned, I think as optometrists, we do recommend over the counter tear supplements. So I thought I will quickly mention about this. So when you are, recommending a lipid-based lubricant for evaporative dry eye, for instance, the compliance is also very important. I know it's a big challenge because when we say 4 times, sometimes they just forget the entire day also. So it doesn't work that way. They have to be strictly compliant for it to show a symptomatic relief as well as improvement in their signs. And moisture retaining spectacles and scleral lenses also play a very important role. Those moisture goggles that they come with side shields, they also provide a lot of relief for very many patients. And scleral lenses, of course, because of the tear reservoir that they have, they offer a lot of benefit symptomatically as well as clinically also. Now, this is the algorithm that I've been talking about, which the management and therapy report gives us. There are a couple of algorithms. So it is etiological driver test to the left that you see. So if you want to check if it's lipid deficient, then you check for the, as optometrists, we do not have access to interferometries in our private practices. So we can always do the meibomian gland expressibility check for the meibum quality. If there is any deficiency in the lipid layer, then you look at the right hand side of this algorithm. It tells you what you need to do. So you can give tear supplementation, which are lipomimetics. The lipid based tear drops can be given. Tear conservation devices like the moisture retaining goggles, spectacle goggles, or the scleral lenses can also be thought about. Then device which stimulates the tears, blink therapies, topical lid hygiene could be thought of. Likewise, for aqueous, for the mucin, you look at the right hand side of the algorithm and look what you can do. For aqueous deficiency, oral nutrition, omega-3 is highly recommended. Now again, you need to exert caution. Not all omega supplements are good. There is omega-6 and there is omega-3 available. Omega-6 is pro-inflammatory, whereas omega-3 is anti-inflammatory. So be very careful about it, because the dream study was a bit of a raked up this issue also, but then the current report supports the oral supplementation with omega-3, which kind of helps in aqueous deficient dry eye conditions. And it's not possible with the given time frame that I talk about each of these elements, but I just want to draw your attention to the availability of these algorithms, which are very simple and easy to understand. Look at the left hand side. These are the diagnostic tests that you can run to confirm that which layer of the tear film is affected. And look at the corresponding right hand side. It is color coded. You just have to follow any of these which would work for your patient. Likewise, for eyelid anomalies, look at the left-hand side. What are the things that you need to look for to confirm whether it is blinking related or lid closure? So incomplete blinking. So what is the treatment that or therapy that you would offer? Blink exercises, simple as that. So there's no complication on that. So if it's a meibomian gland dysfunction, whether it look for the quality of the meibum or lid margin, whether there's any pouting, any missing glands or truncation of the meibomian gland. Then look at the right hand side, and then oral nutrition with vitamin D3 is useful, tear supplementation. All these are evidence based. You just have to simply look at this algorithm and provide the treatment or the management protocol for your patient. Next comes the ocular surface abnormalities. The left hand side again tells you if it's an anatomical misalignment or a neural dysfunction or a cellular damage or an inflammation or oxidative stress related issues, and what are the evidence based interventions that are available that could be offered. You don't have to try all of them that is listed, but you could try whichever you think that could be followed by the patient and which would be most beneficial to the patient. Of course, the surgical options are also always available in severe cases when none of these work, the initial ones work. So the key takeaways from the management and therapy report is that dry eye disease is complex and heterogeneous. It is multiple, often overlapping and pathogenic drivers. It is not one thing that causes dry eye condition. It could be overlap between any of these. Personalized evidence-based management is crucial. Multimodal therapy is often necessary in most of the cases. Tear supplements remain fundamental and the cornerstone for dry eye disease management. The key focus should also be on meibomian gland dysfunction, though that alone is not a driver for development of dry eye disease. You could have a patient who has MGD but is not a dry eye person because he is not symptomatic. So you don't have to, necessarily classify all MGD patients as a dry eye case also. Neuromodulation and biological therapies are promising. When I was going through the report, I also found that, something called blood supplementation also, which has improved the ocular surface inflammation and stuff like that by the finger prick method. It seems you just prick the finger and a drop of blood into your eyes. Of course, it's your own eye that, it's not that you're pricking your finger and putting it in your patient's eyes. It doesn't work that way. So again, the challenge is how much a patient can prick his fingers, 4 times a day. But the results are pretty promising. There have been some RCT studies that have been published regarding this. So couple of random things. Even I came across a study which says laughter therapy has very promising effect on dry eye subjects, wherein there is a symptomatic relief, as well as, clinically the signs also have shown improvement for people who have been undergoing laughter therapy. So all these are very interesting findings that the reports have summarized. Whenever you find time, do go through those reports. It is available freely for all of us. And emerging therapies need more research, and a holistic approach needs to be taken, like lifestyle modifications, pay attention to nutrition, and address the coexisting conditions. Now we move on to the final report, which is the DUCE 3 Digest report, which kind of summarizes the disciplinary dry eye disease research between 2017 and 2024 to underpin the new TFOS DUCE 3 diagnostic methodology and management and therapy reports. It covers 7 core areas, which is sex, gender, hormones, epidemiology, pathophysiology, tear film, pain sensation, iatrogenic DED, and clinical trial design. So I'm not going to be covering each of this, but I'll just touch upon each of this because we'll get an overview of that. So it basically, the digest report emphasizes the complex multifactorial nature of dry eye disease and the need for precise diagnosis and subclassification. So talking about the pathophysiology and the role of sex, gender, and hormones, it is well established that there is a difference in the sex, gender, and hormone play in the development of dry eye disease, especially females who undergo a lot of hormonal changes during their lifetime. And also, one important feature is that inflammation is not assumed in all of the dry eye patients. In cases of evaporative dry eye, they show muted inflammatory response, right? Like for instance, meibomian gland dysfunction, sometimes they may not be symptomatic. You could see, the glands are all blocked, but the patient is completely fine with it, right? So, but then that doesn't mean if they're not symptomatic, just leave them like that. You will, in fact, manage the meibomian gland dysfunction, but there is a predisposition for them to be symptomatic in the near future. So, early diagnosis is very important. And key pathogenic mechanisms remain hyperosmolarity, protease imbalance, glycocalyx impairment, and of course, MGD. So the diagnostic implications of this is that signs of dry eye disease helps identify specific subtypes, while symptoms offer no predictive ability for underlying etiology, which means that just because a person keeps saying that my eyes feel dry doesn't mean that he or she is a dry eye disease patient. Okay, signs, the presence of signs is very important to confirm along with symptoms that this person has indeed dry eye disease. So there have been some advancements in tear film research and biomarkers. Earlier, the concentration only was on MMP9 and MUCA5, which were the tear film biomarkers in the case of dry eye disease. The novel biomarkers that this report mentions are the microRNAs, the tear film lipids, as well as the tear proteome. So, but what are the challenges that given in a clinical setup? So, standardization of sample collection and analytical techniques remain a barrier in a clinical setting. It's more research oriented, but in sitting in a clinic, I don't think any of us would be bothered to be checking, or maybe with the AI involvement, maybe these things could become a reality, that sitting in the clinic also we are able to, identify these tear film biomarkers in, kind of sub-classifying dry eye disease. The future is not too far. So talking about pain and sensation, the role of pain and sensation in dry eye disease, ocular pain is linked to the structural integrity of corneal nerves. We all know that the cornea is a highly sensitive organ because it is richly innervated by the nerves. So corneal sensitivity will give you important clues. So when you have somebody with dry eye disease, so, ocular discomfort or visual discomfort is something which is normal. But when somebody is complaining of pain, it not necessarily, drives you towards a dry eye diagnosis. Okay, it provides insights to somatosensory abnormalities, and it could be, the cause could be different. It could be a nervous issue. Now, there is something called the topical anesthetic challenge test, which is a very simple thing that you can do. So somebody says that, they experience pain, which is not a common thing for dry eye disease person. But if somebody says pain, now there could be the central nerves which are affected, or the peripheral nerves of the cornea that are affected. To identify which set of nerves are being affected, you just put a drop of paracaine in the eye, and when the patient says that there is immediate relief, it means that the peripheral corneal nerves which are the problematic over here, not the central nerves. Now, even after instilling the anesthetic, the patient still experiences pain, then it is the central corneal nerves that are being affected. So that is one. So it is more a neural, pathophysiology that is involved here. So pain management becomes the modality of treatment over here. Of course, it is beyond the scope for an optometrist, but at least the diagnostic part of it we can do. So this is a very simple thing that you can think of. So when the cornea is very sensitive, they experience pain. Okay, so pain management, you need to identify whether it is the central corneal nerves that are affected or the peripheral corneal nerves that are being affected over here. Again, there could be a situation where there is no sensitivity also. That happens in neurotrophic conditions. So here you need to have an esthesiometer. The Coque-Bonnet esthesiometer could be used. If you do not have access to that, then even a cotton wisp could be tried. You just have to touch, the minute the patient reacts to it, that means the cornea is sensitive. If not, then there is a loss of sensitivity. So in the case of loss of sensitivity, you will not be doing this topical anesthetic challenge test, of course. So the modality of treatment would be towards handling the neurotropic pain sensation. So again, there's another core area, which is the iatrogenic causes of dry eye disease. It could be multiple. It could be medication-induced dry eye disease, like any usage of antihistamines, corticosteroids. All this could cause dry eye disease. Or contact lens wear is a known risk factor for development of dry eye disease. And procedure-induced dry eye disease like botulinum toxin, which is gathering a lot of traction over the recent past because of the beauty therapies. People want to get rid of their crow's feet or wrinkles over their forehead, and they're going for these botulinum toxin injections, which is also causing dry eye disease in patients. Radiotherapy, all of these could cause dry eye disease. Talking about innovations in clinical trial design for dry eye disease, I'm just going to skim through this. There are evolving regulatory endpoints. The US FDA has recommended that 10 mm Schirmer score increase and symptom improvement should be there whenever there is any clinical trials that are being done. Also, they are acknowledging the role of vehicle effects in the tear supplements. For example, when they add water, that could also be a confounding factor. So they cannot claim that this particular tear supplement is the most effective. The confounding factor could be the excipients or the water or the placebo that is used in these tear supplements. So the regulatory pathways exist for devices that target any meibomian gland secretion or mechanical tear stimulation. So just to summarize the digest report, these are the 7 core areas that have been discussed exhaustively. Of the 3 reports, the digest report is the most exhaustive, I would say. I've not been able to read each and every word, but majorly I've tried to cover all of it. So we have the pathophysiology, the pain and sensation, clinical trials, tear film, sex, gender, hormones, epidemiology, and iatrogenic core area that they have kind of, touched upon. This last slide gives you the key findings from the digest report. You look at the top row over here. These are the drivers for dry eye disease, like tear film lipid abnormalities, tear film aqueous abnormalities, mucin abnormalities, anatomical juxtaposition abnormalities, blink lid closure abnormalities, lid margin abnormalities, nerve abnormalities, ocular surface cell abnormalities, inflammatory or oxidative stress abnormalities. Now, how are they influencing these core areas that the digest report has identified? So you have this checklist over here. What is driving what? Okay, that is very simple, again, freely available. So I personally like all of these, simple, tables that they have given, the algorithms, the pictures, all of this, it's very easy for anybody to understand, even if you don't have that much of interest on research, or you want to know what publication, what result, or which RCT or any of this. You just look at these algorithms to kind of understand and straight away implement in your clinical practice. So that's the best part of all of the 3 reports that have come up. So the key takeaways from the T-Force DEUCE 3 report is that they have redefined dry eye disease. It recognized as a multifactorial symptomatic disease, standardized the diagnosis of dry eye disease by the use or recommendation of OSDI 6 questionnaire. NITBUT, tear hyperosmolarity, and ocular surface staining are the key markers. Subclassification matters. Etiology-based approach helps in targeted management. Personalized multimodal therapy is the way forward, wherein you have tailored interventions. Digest Insights emphasizes on the sex gender influences, pain pathways, iatrogenic causes, and innovations in biomarker and trial design. Future directions are towards integrating AI into practice, digital diagnostics, and biomarker profiling for precision care. So having said this, holistic, evidence-based, and patient-centered approaches are essential for improving better patient outcomes in dry eye disease management. And always remember, one size does not fit all. So with that, I would like to thank all of you for joining me today. And thanks once again to OCI for inviting me and making me part of this webinar. And thanks once again. Over to you, Paula.
Thank you, Anita. And we are open to questions now. You can please type your questions in the chat box. We will take the questions. Anita, meanwhile, we have few questions coming up. I have few, as you said in the last slide, that all size doesn't fit everybody, but uh, is there any specific kind of a personalized treatment plan, which is like a generic, which can be kept in a clinic and can be worked on it?
So, like I mentioned, all those algorithms which I showed, they're very specific. So you identify what is the cause and then the intervention, which is again evidence-based. So you can just take a printout of it and paste it. It cannot get any simpler than that, because there are multiple things that get caused, and there could be an overlap between multiple subtypes also. So there's not one size fit all. Again, I would reiterate that. So we need to work on mix and match. You could pick up one from this, one from that, or just one from one algorithm only. So it works.
So they are basically ready references, but it is better to have them handy. Yeah. Okay. 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 So we have one question. Are you asking about symptoms or causes? This is for what? Okay. Okay. So the other
I
question is, yeah, are there any new tools or questionnaires recommended to assess symptom severity or quality of life impact?
So the OSDI 6 is just a symptomatic screening tool, I would say. So it doesn't stop you from using the other questionnaires. When you say it's a screening, it is simple and easy to, kind of, administer. That because in a clinical setting, nobody will, sit and answer your 20, 50 questions. They don't have the patience also. So in a clinical setting, when you have patients waiting outside your room, you can just share these. So with that, you get the symptom score, just a screening score to tell you that, okay, this patient is symptomatic, and then you take the following steps. That is all. And quality of life, vision related quality of life questionnaires are also available. That is separate. It is not combined with this. You can run it as a separate entity. So you have OSDI 12, DQ5, speed questionnaire, McMoney's dry eye questionnaire. There are hundreds of questionnaires available in the market. If you really want to focus on that particular, you're free to use. But the recommendation by the T-Force Deuce 3 report is that you can simply run to come to a diagnosis of a dry eye is very, very important, because there is a lot of misunderstanding within the ophthalmic community as to who exactly is a dry eye patient. So simply when you notice somebody with MGD, we assume automatically that this person is a dry eye patient, but that's not the case always. So that is the main focus of this report.
Okay, okay. Okay, we have few questions. One is from Mr. Piyush Sinha. He's asking how to differentiate between preclinical dry eye and neurotropic keratopathy in asymptomatic patients with poor TBUT and low Sherma.
So why will you want to differentiate all of that? So if it is a case wherein a patient is asymptomatic, so when the patient has no symptoms, that means there is somewhere there is a loss of a sensation. You need to first ascertain that by running a simple corneal sensitivity test, whether it is a neurological element that is attached to it. So that only will give you important clues. And next step follows. So you could have a person who has a tear film which is not stable. So what is causing that instability, that you need to identify and tailor make it accordingly. So there are different elements to it. There are different tests to identify each of these elements. So neurotropic keratopathy could be one cause of it, loss of sensation. There could be other conditions which causes loss of sensation in the cornea. So you need to identify. Of course, all this has to be managed and referred to an ophthalmologist to be managed rather.
Okay, I hope Piyush, you got your answer. We have Mr. Rakesh Kumar. He is asking about what about blue light and dry eyes? I am guessing it is blue light because there's no correlation between blue eyes and dry eyes. Maybe some mistake. Yeah, so blue light and dry eye, because some studies show that blue light does not cause dry eye, and some suggest it causes. So, any comments on that?
So if you're talking about blue, we don't talk about blue light as such, because the focus of this paper was on digital eye strain, which is recognized as a consistent risk factor in development of dry eye disease. So digital eye strain is what we are talking about. Blue light is everywhere. So even now, presently, blue light is everywhere. So I can't really say that blue light causes dry eyes. So there could be things that, added to the blue light, which is causing dry eye. So we cannot just pinpoint that blue light is causing dry eyes per se, if I understand this question correctly.
Okay. Dasika is asking, she has a patient who is 67 years old, and she always complains that she feels hot air coming into her eyes whenever she wears spectacles and her glasses get fogged. How to help her? And also, she says that she has profuse watering, but her puncta is normal.
Okay, so again, you have to run through this same thing. The algorithm is going to help you first pinpoint whether it is a true case of dry eye disease, because considering her age also, and if there are any systemic disease that she has, you need to identify that also. First, you run through the simple algorithm of whether the person is symptomatic. So again, you need to differentiate between pain and discomfort. Okay, then comes the clinical signs, the tear film, all of those you can conduct. So when once it is confirmatory, what are the other, there are so many risk factors that have been identified, and also the subclassification, and then you target each of those areas and follow. As far as fogging of spectacles are concerned, I mean, you need to look for, anti-fogging agent that are available for your spectacle lenses. There cannot be any air coming out of the eyes that is fogging the spectacles. Of course, it is an external humidity difference that is causing the fogging up of the glasses. Like for instance, even when you're wearing the mask, all of us who are wearing spectacles, we did face this fogging of the spectacles. So
Yeah, also maybe Dasika, you can check the distance at which she's wearing the spectacles. Sometimes if it is too near to the eyes, and if the person is sweating,
yeah,
that kind of a fogging happens. So yeah, that can also be a reason.
sensing point
So
of you need to know.
yeah, yes, yes. Okay, we have one more. Are there any new non-pharmacological approaches to treating dry eye in 2025?
There are plenty of it. I mean, not necessarily, there are any device-driven approaches, especially the main focus of the diagnostic therapy report was on device-driven devices for managing MGD, like, warm compresses. Also, they recommended temperatures around 40 to 41.5 degrees centigrade for warm compress, and every warm compress should be followed by massages and then expression of the meibomian gland to manage this. So this is again non-pharmacological thing. Tear supplements definitely become the cornerstone, like I have been reiterating that. But you have different tear supplements also, one with preservatives and one with non-preserved tear supplements also. So you need to identify if something is not working in 4 weeks, then you need to switch over. If you find that the signs remain the same, but symptomatically the patient is feeling better, then you need to give them some more time for it to work. So most of the tear supplements are over the counter. So only things like, cyclosporin or any corticosteroid, loteprednol, all these are prescription drugs. So that needs to be exerted with caution, of course, by an ophthalmologist. It is not in the scope of an optometrist. So I would, freely ask you to recommend tear supplements which are available over the counter, and not, most of them keep trying different tear supplements here and there, and that is why it is frustrating. They hear it from their friend or relative, and then what works for the other person may not work for them. So that's where most of us are going wrong. Also, we are not able to identify which layer of the tear film is being targeted by giving a tear supplement. So now with the availability of tear supplements in the market, we need to be having a very targeted, tear supplement recommendation also for our patients. So a non-pharmacological, there are plenty, IPL, your Lipiflow, your iLux, so many things, low level light therapy, the blue, the red light therapy, that is also very common. IPL therapy is common. Then, there are plenty that's available.
I guess, Khalid, your question, the answers, I think, is hidden in what Anita said, and of course, the report she shared. So, treatment modalities are being discussed, were discussed. So, I'll pass this question. There's one more from Kulsum. She's asking, what potential directions may future research on Mediterranean diet take?
So Mediterranean diet was earlier thought to be a risk factor for development of dry eye disease, but the current literature supports that it is inconclusive, which means it is not really a causative agent for or a risk factor for development of dry eye disease. So it's not going to be a problem.
Okay. Any suggestions on lifestyle changes or environmental health to kind of cope with the
So
dry eye?
again, like I did mention about, the analysis of the work environment, like most of us working under air conditioned environments where we are sitting in front of our desktops, laptops, and where there is low humidity. So desktop humidifiers are very much available, or sitting close to the vent means you need to move away from that area. Wherever the air is very dry, then humidifiers are definitely the go-to recommendation for all these people. It really helps. Then tight fitting moisture retaining they're called goggles rather. So they are with the side shields, so they retain the moisture around the eyes. So these kind of help. Then uh, is there anything else that they wanted to know?
I guess there will be questions, but we are running out of time. Now, just picking the thread up from the question of lifestyle changes, I just wanted to share with all the audience that as a part of promotive healthcare, OCI has been creating IC materials and sharing it with their members. Is my screen visible?
Yeah.
Yeah, so this is the for July month, we have kind of created this IEC material, and this is as a part of promotion and awareness amongst patients. So you can use this if anybody wants it with their practice logo. You can write to us at info@ocindia.org, and we can incorporate your practice logo, and we can send it to you, and you can use it as an awareness material. This is free of cost, and we hope you will be using it. We can share the link with you. Bhavya, if you have it, you can maybe share the link, or I can also put the document there. All right, okay. So I guess we have few questions, but then I am just putting the email ID of OC India. It is info@ocindia.org. You can post in your questions, and we will send it to Anita, and Anita can respond back, and we'll get back to you.
Yeah.
So, yes, so just a minute, if I can, then I'll yeah, yes. So the IEC poster also, I have posted it. If you want, you can download it, and you can start using it and show it to your patients for general awareness. And thank you so much, Anita, for taking out time and sharing your insights. I'm sure it has been an insightful session for everybody. And yeah, we have kind of finished on time. Thank you very much. See you in August.
Yeah, thank you so much for this opportunity, and thanks everyone for joining me here. I hope you found this useful and insightful. I mean, I thoroughly enjoyed this session, and I hope you enjoyed it as well. So if there are any questions, I'd be more than happy to respond. As Paula mentioned, I can answer it over mails also, or you connect with me over WhatsApp or any of the social media. I'm more than happy to help. So that's from me. Thank you so much.
Thank you. Thank you, everybody. Bye, Anita.
Bye bye.